Hi, everyone. Welcome to another episode of the Talks here at the Journey Towards Healthy Living. For this month's episode, we'll be diving into Movember. I would like to start off this episode with a quote from the Movember website, which is where we got some of this info. So I will encourage you guys to check it out. And the quote goes, "Our fathers, partners, brothers, and friends are facing a health crisis. Yet it's rarely talked about. Men are dying too young, and we can't afford to stay silent." I think it's a pretty good quote, and it kind of embodies what we'll be talking about for this episode. I'm here with Daniel and Dr. Bobby, and we'll be diving into some topics.
So I think we could just start off with an introduction from you, Dr. Bobby Shayegan.
Yeah, thanks for asking me to join your podcast. It's so I'm Bobby Shayegan. I'm a urological oncologist and the head of the Division of Urology at McMaster University. While I'm a urologist, I don't really do any general urology, and the vast amount of my work is really on prostate cancer and secondarily bladder cancer. But as a uro-oncologist, in my practice, I've certainly treated men with other diseases specific to men, such as testicular cancer and a much more rare penile cancer as well. So Movember is a special time, I think, for urologists. Prostate cancer in particular is a significant amount of work for a lot of urologists, even if they don't specialize in prostate cancer, excuse me. So I'm happy that these fine young gentlemen have decided to take this on and get the message out. So looking forward to it.
Cool, thank you. The first thing I was just kind of wondering was, you've probably gotten this question a bunch of times, but what kind of swayed you along the path of urology and all of that stuff?
Well, I wish I can give you a very nice story that was inspiring, but it really didn't start that way for me. I sort of always knew I was good with my hands, and I was always interested in the human physiology. So my undergraduate degree was in human physiology at UBC. The natural progression was medical school, which I did here in Toronto. And then residency, I really wasn't focused enough early on, and I actually went to general surgery. And after a couple of years in general surgery, I wanted to have a much more finite focus, so I transferred into urology. And then within urology, it's a pretty broad field. And while you can certainly become a general urologist, I elected to pursue urological cancers, thus a uro-oncologist, and that was by way of a fellowship in New York City at Memorial Sloan Kettering Cancer Center. And so it was really an odd set of circumstances, but once I was in it, it was pretty clear that this is what I was going to do.
Interesting. Now, something I'm wondering is just because this kind of thing can be confusing for some people. What is the difference between prostate cancer and testicular cancer?
Right. So very, very different organs and tumors. So the prostate is an organ that's not, a patient can't feel it. It's deep inside. It's situated just below the bladder, and the male urethra, which is a passageway through which one urinates, runs down through the center of the prostate. The function of the prostate has more to do with urinary control and fertility, whereas the testicles are lying in their appropriate position. Is supposed to be within the scrotum, and their primary function is really production of sperm for fertility as well, along with testosterone in men. So testicular cancer is an uncommon cancer, but is the most common solid tumor in young individuals, teens and upwards. It is not a common disease within men who get prostate cancer, and that's an entirely different age group. Testicular cancer is uncommon, but a potentially a very treatable and curable cancer, unless it's missed, and it's a disease of the young. Prostate cancer is certainly a disease that really 40s and above is the majority, but most of our patients in their 60s and 70s. And it's also a very, very prevalent disease, but there is no interrelationship between testicular cancer and prostate cancer.
Nice. I liked how you touched upon if it gets caught early. So the one thing we really wanted to see was, is there any early detections or like a little thing that someone could do at home?
That's it for what, testicular cancer, certainly. Prostate, we can get to in a minute, but testicular cancer, you know, there is no broad screening programs as one would find, let's say, in breast cancer or cervical cancer. And so testicular cancer is probably the best way for early diagnosis is men perform testicular self-examinations. It's a relatively simple thing. You know, we always advise our patients when they're in the shower, when they're cleaning themselves, examine your testicles, get comfortable with how it should feel. And if one side to the other side feels dramatically different, or it feels irregular and hard, just doesn't feel right, get it checked out. And the biggest problem we have is that young men, being young men, often avoid physicians' offices, and even when they know there's something is not right, they don't seek care immediately. So unfortunately, many of the cases of testicular cancer that we find are much more advanced than they should be at diagnosis. But that, be that as it may, it's a cancer that has become a model for the combinations of chemotherapy and surgery. And broadly speaking, 90% of patients are cured with therapy. But there are consequences to the therapy, unfortunately. Prostate cancer, an entirely different matter. It's a much more controversial thing. At home, there really isn't much a man can do to self-screen, I suppose, for prostate cancer. And broad screening programs have been controversial since a number of years ago in the United States, and subsequently in Canada. The recommendations were made to urologists and family physicians to stop screening. And so this is an area of significant controversy, but screening for prostate cancer is really a blood sample for a protein called PSA, and a rectal examination to feel whether the prostate has nodules on it. Unfortunately, neither are being done with adequate consistency. This is normally done in the primary care setting by a family physician, but family physicians have been given advice that we as urologists do not agree with. And so the prostate cancer screening and early detection is a matter of controversy, but in the last 7 years, by decreased screening, we're seeing increased rates of younger men showing up with incurable disease because they were never screened. This has also been registered in all states in the United States. Every single state has reported higher incidences of incurable metastatic or disease that's already spread of prostate cancer. And of course, that's a bad trend. We don't want to see things increasing, but this is a complex area. And I think patients should feel empowered to approach their physicians and request to be screened, in particular if they're at higher risk. So who's at higher risk? Well, if you have multiple male members of your family, especially close relations with prostate cancer, if you're of African heritage, you are at an increased risk. And also, if there are multiple family members with early onset breast cancer and ovarian cancer, these could also be clues as to mutations that one may carry that may predispose each individual to prostate cancer. So unfortunately, it has transitioned from a mass screening situation to very little screening. The right thing is somewhere in the middle, is what we call smart screening based on risk. But there is no easy way for a man to self-diagnose with prostate cancer, unfortunately.
What plays into the role of the controversy? Why is it so controversial?
So that's a good question. If you think about analogy, breast cancer, mammograms were being done on a mass scale. And if you found a lump on a mammogram, we get a biopsy, and that would lead ultimately to treatment. The problem with prostate cancer is that of those who are diagnosed early with prostate cancer, about 40% do not have the type of prostate cancer that may result in a risk to one's life if not treated. And the risk of mass screening is a lot of over detection of what is likely clinically insignificant cancers. And the risk, furthermore, is that if those patients are subjected to treatment, it may be unnecessary, overzealous, overaggressive therapy that carries cost to the system and carries side effects and likely an adverse impact on that individual's quality of life. And so that's the fear, is over detection, over treatment through mass screening. But I think stopping screening is not the answer. The answer is smart screening. And if you do happen to pick up a patient who obviously has disease that's not at risk of rapid progression, then that patient should be advised to be under observation or surveillance versus active therapy. Unfortunately, there are many jurisdictions outside of Canada, because its treatment is remunerative for the physicians. There can be a bias towards treatment because of remuneration. That is not the issue in Canada, where physicians are generally overburdened and certainly not looking for more patients. And so we are quite diligent about not over treating. But unfortunately, when the screening is lessened by such a big magnitude, the net effect is we're going to see patients with missed cancers that were important cancers, and they are being now seen at an incurable stage.
Right. And then I think you're doing, just want to talk about your research quickly. Do you want to explain what is metastatic castrated sensitive prostate cancer?
So prostate, that's a good question. Thanks for asking that, Daniel. So the prostate cancer, it's such a confusing and convoluted disease that in order to make it more digestible, not only for patients and physicians, but also to do research and clinical trials, prostate cancer has been divided into these sort of silos of what we call clinical states. And pretty much you can place every patient to one of these silos. And so one of those silos is the first question is this patient metastatic or not? These are two big silos. Mm-hmm. Metastatic would mean that the disease is outside the prostate now and has spread. And the most common site of spread is the bone, which carries morbidity. Now, once you establish metastatic, if a patient's in a silo of metastatic disease, the next question is this patient already on hormone therapy and are they responding? That makes them, and since the hormonal therapy causes a state of low testosterone, another way to describe a low testosterone state is to say the patient's castrate from castration. And if they're responding, then they are metastatic, but castration sensitive. In other words, they're responding to the hormonal therapy. The patients often, inevitably, if you live long enough, one becomes castration resistant as the cancer cells learn to develop mutations that allows them to circumvent the state of low testosterone. So that's a state that's further along the pathway or the journey of prostate cancer. So being able to divide patients into these distinct states helps us be able to conduct research into each of these spaces. And the majority of the research today is on advanced therapeutic drugs or therapeutic mechanisms to treat advanced disease. On the earlier end of disease, it's really about surgical and radiation technologies, of which I'm also very interested in. Do a lot of robotic surgery for prostate cancer.
So, Phil, you were going to ask a question?
Yeah, just what you just said. How would that look like, a robotic surgery for prostate cancer?
So if a patient's been diagnosed with prostate cancer, let's say through good screening, and they don't have the type of disease that we feel safe in watching alone, as I said, 40% of these patients, we can just watch them. That's called surveillance. The remaining ones, if they are felt to be curable, because the cancer is still important, but confined to the prostate, again, broadly speaking, there are two options by benchmark standards. One option is radiation, and one option is surgery. Surgery pretty well involves the removal of the prostate and reattaching the bladder to the urethra and removing lymph nodes in the area. Historically, and even the way it's done in about, I would say 70% of Ontario, is through an open incision. And there's nothing wrong with that. It is still probably accounts for the vast majority of the cases being done nationally in this country. But there are, of course, some challenges. You know, there's an incision, so there's pain and discomfort associated with it. There's a lot more blood loss, and there are other individual nuances that can be circumvented or mitigated by a different approach. So robotic surgery is like laparoscopic surgery or keyhole surgery. The difference with a conventional laparoscopic or keyhole surgery is that you hold the instruments in your hands adjacent to the patient, and the fulcrum is at the abdomen. So you have a lot less, let's say, freedom of movement in the patient. Robotic surgery, the surgeon is not at the bedside. The robot actually holds on to the instruments, and the instruments have a wrist, an endoscopic wrist that can move more than a human hand can. But the surgeon sits away at some short distance away from the patient on a console and controls the movement of the robot in a three-dimensional world, because the robot has a right and left eye, and you basically see in 3D, like 3D IMAX. And the net effect is that you have much better depth perception, much better accurate movements. And the ultimate result is a lot less blood loss, more accurate surgery, definitely a better experience for the patient, and a much shorter length of stay. We, in fact, in Hamilton, send about half our patients home on the night of surgery. That's a distinct departure from conventional open surgery. The caveat is cost. They say, why isn't everybody doing it? Well, there's training and cost. Robotic surgery is exceedingly expensive. Not exceedingly, but it's expensive. And the Ministry of Health hasn't kicked in a single dime into this yet. We have pressured the Ministry of Health. We have lobbied. We have met with them. And I think hopefully the Ministry of Health is now starting to open up to the notion that this should be rapidly an evolving standard of care. So whereas most university centers in Ontario have robotic systems, the vast majority of community-based hospitals do not. And the majority of the patients in the province are still operated on at one of our numerous community hospitals, and many excellent ones, but most do not have robotic platforms.
I thought what you're talking about with that the prostate cancer usually metastasizes to the bone, you were saying?
It does.
Yeah, I found that kind of interesting because I do brain metastasis research, and like we see usually melanoma, breast, and lung usually go to the brain.
Right.
Has there been any research to kind of elucidate the pre-metastatic cells or anything that?
Oh, yeah.
Yeah.
For sure. There's a lot of basic science and translational research on everything. They're mostly done on cell cultures, different cell lines from prostate cancer. But all of these cell lines had been extracted from other patients, 30, 40 years ago.
Right.
And the majority came from the bone. Prostate cancer does have a predilection for bone, even within bone, not any bone. It does like the axial spine. So it likes the spine, the pelvic bones, the ribs. It doesn't really go much below the elbows and below the knees. So it has a certain preference for where it goes in the bone. As to why one patient may have predominant bone disease versus another patient has no bone metastasis, but has lymph node metastases, that has never been elucidated, or it's not certainly predictable. But what we do know is, depending on the pattern of metastases as to where they've gone, you can prognosticate that patient's ultimate survival. Bone metastases and liver metastases are terrible.
Right.
But lymph node metastases, those patients do very well for a long period of time on hormonal therapy. But in being able to predict which patient may metastasize in which direction, that we're nowhere near that.
Okay.
We do not have, even through genetics and sequencing, we can say that, this is going to be an aggressive prostate cancer or not.
Right.
but we can't predict the pattern of spread.
Okay. Yeah, I guess the cells are very putative at the time where they would probably make the decision or self-fate decision to metastasize and what.
Yeah, exactly. And once they metastasize, they'll gain new somatic mutations,
right,
and they'll constantly change. So what may be effective at the outset often is not after a period of time.
Mm-hmm.
And that period of time varies in between different patients. But certainly these tumors will change through acquired mutations, or what we call somatic mutations. But the drug industry is trying to keep up with that. And so I can say to you that in the last 7 to 10 years, it's almost been a revolution in therapeutics in prostate cancer, where before that, we really, besides hormonal therapy, didn't have much. So we've gone from, famine to feast in the last 7 to 10 years.
What are like the new therapies that
So we have ranges of advanced oral hormonal therapies, drugs like abiraterone, enzalutamide, darolutamide, and apalutamide, and the list goes on. There's also other technologies where we call them theranostics or radiopharmaceuticals, where patients can receive a drug which in effect is an antibody that seeks out prostate cancer, but the antibody is tagged to a toxic payload, usually a radioactive isotope. And so you get significant responses. So we've been able to extend life significantly. We've been able to improve the quality of life of these patients because, obviously you don't want to extend life if the quality of life is substantially degraded. So, but we haven't been able to cure advanced patients with any real consistent manner. And so that seems to elude us still. But there's no doubt we're further today than we were 10 years ago by a long, long margin, big margin.
Have you seen like the use of immunotherapies or any sort of thing?
Well, immunotherapy, unfortunately, has been disappointing in prostate cancer.
Okay.
Not the way it's been in melanoma. Melanoma is probably the model for immunotherapy because the cancer itself is highly immunogenic and has neoantigens that if unmasked, your body can respond to, and that's the role of immunotherapy. But prostate cancer tends to be what we call a cold tumor, so it is not immunologically very active, and hence, at least in the early periods of therapy, immunotherapy is not effective in prostate. Now, there has been some interesting signals in patients who are heavily pretreated, because towards the end, the tumors may become so different that they do become immunogenic. But for now, I would have to tell you that there isn't any real exciting development in immunotherapy as it pertains to prostate cancer.
Okay. And is there a high rate of like relapse with prostate cancer patient?
Sure. It depends on, what stage the patient presented at. If in the surgical patients and radiation patients, of those that we take to the operating room, on average, about 20 to 30% were relapse, but the majority of those relapses can be salvaged, and the patients often do not die of prostate cancer specifically. But of the patients that present with metastatic disease, the picture is much more grim. That survival was on average, maybe up to 5 years, but that has gone substantially better.
Okay. Yeah, because I read a paper about how metastasis could happen very early on in cancer, and like say if we take out the prostate, like those cells already metastasized and
right,
they're just like dormant. However, upon the right microenvironment, they could start to so
that's shown. That's an interesting thing that you've raised. Yes.
Yeah.
Certainly any patient that relapses after therapy of their primary tumor, it would suggest that they already had metastases at the time of therapy, right?
Yeah.
But there are some very unique patients that had metastasized, but never really developed clinical metastatic disease. Mm-hmm. And the example of this is in patients who have their bladder and prostate removed for bladder cancer, and their lymph nodes are shown to have prostate cancer in them, suggesting that he also has prostate cancer that's already spread.
Yeah.
And in fact, these patients without any therapy do really well for a long time. So prostate cancer, this is the reason why this is a particularly challenging disease, because it's so heterogeneous in terms of the population of patients and how they behave. And it's such a convoluted space that I would say to stay on top of it nowadays, you need a multidisciplinary group of physicians. And it is very similar in many ways to breast cancer. It's a good analog of breast cancer. Whether you're talking about its incidence or its mortality or case mortality and whatever, hormonal responsiveness, it is effectively the version of breast cancer in men. And so, it's a challenging disease for sure.
Mm-hmm. So I guess since our podcast today is about Movember, and not only does Movember look at like prostate and testicular cancer, they also look at the mental health and stuff. So could you maybe shed some light in maybe the mental health of the patients that you work with?
Absolutely. So, I mean, mental health is another huge arena of interest for society and clinicians. And McMaster has a huge mental health interest. St. Joseph, for example, our West Fifth campus has a very large mental health program up there. And so there's lots of things that affect mental health in general, right? But you can imagine as a man being told that you have prostate cancer, no different than anybody else who's given a cancer diagnosis. It's going to impact their mental health, whether it's anxiety, depression, or a combination. There's no doubt that this affects patients adversely. I don't think in this country we've done such a great job of having complementary services for patients diagnosed with disease in terms of mental health. But I think it behooves all of us as cancer doctors to ask a few questions about the patient's overall well-being mentally and offer them counseling or even psychology or psychiatric consultations should they need it. In an ideal world, you would have a complementary set of services offered to cancer patients, which would range anywhere from nutrition advice, rehabilitation or prehabilitation before treatment, all the way through to mental health exercise programs. A lot of the cancer treatments result in significant fatigue, and exercise programs, actually, when it's an organized exercise program, does a lot to combat these things, maintain their overall well-being and health. A lot of the drugs that we use in prostate cancer have a significant adverse impact on psychiatric well-being. Hormonal therapy in men, for example, effectively results in a state very similar to menopause: hot flashes, mood swings, issues with memory and cognition. And so if there's any underlying, depression or anxiety, this is certainly going to make it worse. And I don't think we do a great job there. And I think that should be one of the goals, is how to bring additional complementary services to patients that have been diagnosed with cancers and they are struggling with a diagnosis. And that's beyond prostate cancer. I think that's true with any cancer. And I think last 2 years of COVID isolation really hasn't helped with the mental health of anybody. Physicians, patients, students, my kids at home. It affects their mental health. So mental health has a stigma that it shouldn't have. It's a disease like anything else, and there are treatments. So I think that's a very important point that you raise, whether it's a primary mental health issue or mental health impact as a consequence of a cancer diagnosis.
I have a question now that you have brought up stigma. What are your thoughts on the stigma about going to the doctor to get a prostate exam? And what has been the representation of how that goes usually?
Well, I don't think there's a stigma, honestly. I don't think there's men know what to expect, and I think the big joke always is in magazines and cartoons about bending over and getting the finger up the rear end. But really, that should have happened in the GP's office as well, because the rectal examination is part and parcel of screening. So if a family physician is doing a PSA and wants to refer a patient to a urologist, technically that screen is not adequate unless they've also had a rectal exam. And rectal examinations go beyond just prostate cancer. You can detect rectal cancer at times. And yes, no man wants to, be probed. That being said, I think the physician's job is to put them at ease. And, if you do it, with a little bit of compassion, it's not that those patients don't walk away thinking, I'll never do that again. So, there may be a bit of a social stigma, but I don't think it's well-founded. It really should be a part of the annual periodic health exam by family physicians. It often is not, unfortunately, but urologists, this is sort of part and parcel of our practice.
Awesome. So I wish we could talk forever, but I think it's come up to the last few seconds here. If you want to give any sort of end note.
Yeah, no, I thank you both of you guys for doing this. I think it's very noble that you guys are putting this out during Movember. It's a common disease. Somewhere around 1 in 8 or 9 men will get it in their lifetime. Mortality from it is much, much lower, but that's because the majority are not aggressive cancers and the majority are so-called indolent. But unless one is tested, you will never know. And if you have it and it's an aggressive one and you're not tested, by the time one develops symptoms in prostate cancer, it's often too late to cure. So best to know. And I think in our environment today, the patient should take the bull by the horn and request to be screened, understanding the pros and cons, because there's a discussion with a GP that has to be had about what downsides of screening are. And in terms of testicular cancer, this is a disease of the young, and young men don't necessarily follow advice all the time, but it's as simple as once a month when you're taking a shower, examine the boys down there and make sure they feel normal. And if they're not, go to your doctor. There's no embarrassment. Again, the consequences of a missed tumor are too significant to worry about embarrassment.
Yes.
Thank you so much, Dr. Shayegan. I hope you have a wonderful day.
Thanks very much, guys. Have a good one.
Thank you for your time. Bye.
Bye.